Previously, the virus was called 2019 nCoV, so 2019 novel coronavirus. And SARS obviously stands for severe acute respiratory syndrome. So that's the virus. Then the virus causes a disease, which is called COVID-19. So coronavirus disease, and 19 because it started in 2019. And colloquially, you can, because it's a bit difficult to say SARS-CoV-2, many people, including myself, just say COVID-19 virus when we want to communicate about the virus itself. And that's basically what I will be using also in this lecture. So starting in, what was it, December 2019, from China, we've seen a global spread of the new COVID-19 virus. And it's pretty unprecedented. Most people didn't really expect it to spread this much and this fast. But now it's more or less global. And well, what you see in this figure are the cumulative number of reported cases per 100,000 inhabitants. And as you can see in the map, there are a lot of cases in Europe, in North America, Australia, with especially many reported from Italy, Spain, and, well, Iceland is a bit special because they have a really small population. So I thought I'd share this simplified tree of life to get an idea of what viruses are. And you may see that we have bacteria here, different kinds. We have archaea, which are, well, one of the kingdoms, and we have the eukarya. For instance, mammalians are eukaryotes. But as you can see, there are no viruses here. So what are viruses? Are they even life? And most people would actually say that viruses aren't alive. Some think that viruses are some sort of in-between thing between life and non-life. But what it hinges upon, at least for me, is that viruses don't have any own kind of metabolism. They cannot replicate by themselves. They don't grow. So it seems like they're just more or less capsules containing some DNA that is able to multiply when it infects a host. So we can't really talk about the phylogeny of viruses, but we can talk about types of viruses, or we can classify them in different ways. And here on top you have a sort of general picture of what a virus can be. So you have a capsule with some proteins. Some have an envelope, which is a lipid layer from the host cells. And they may have a capsid formed of proteins, which contains then the genetic material of the virus, and some proteins that help it getting started when it infects the cell. And one way of classifying viruses is to look at what kind of genetic material they have. As you know, humans and, well, essentially all life forms have DNA, which is double-stranded. And there are a few viruses that have double-stranded DNA. Herpes viruses, for instance, pox. But there are also some small viruses that have single-stranded DNA. And there are viruses who don't have DNA, but they have RNA. And generally, you would say that, well, I would say that most RNA viruses have a single strand of RNA. So that's what this SS stands for. The plus means that you can read the RNA directly and make a product out of it, whereas the minus is sort of a negative copy of the RNA. So it needs to be first photocopied into a positive RNA that can be used for protein synthesis. And among these RNA viruses, we have a coronavirus. And then last, here in the right side, we have also single-strand RNA viruses, but they're a bit special because they're what's called retroviruses. So they have a single-stranded RNA, which is then transcribed from RNA to DNA. And then that new DNA is then transcribed back to RNA. The typical example of a retrovirus is HIV. So what about coronaviruses? So there are 4 classes of coronaviruses, or in general types, whatever you want to call them. So there are alpha, beta, gamma, and delta. So according to Greek alphabets just. There are 6 types of coronavirus that are common in humans. All of them belong to the alpha and beta classes, and essentially all mammalian coronaviruses come from or belong to the alpha and beta classes, whereas gamma and delta are mainly bird viruses. And most of these coronavirus strains cause a mild upper respiratory tract or gastrointestinal tract infection. Obviously, apart from COVID-19 virus, but also SARS and MERS. They have a genome that's a single strand, positive read RNA, and it's about 30 kilobase pairs, or kilobases, not base pairs. And it has a number, I think it was 16 reading frames and even more proteins that it codes for. But some proteins are noted here in the basic structure of a coronavirus. So you have these glycoprotein spikes, which are notable. And you have membrane proteins, but it also has a lipid bilayer membrane and a couple of other proteins as well. So just to give you a sort of idea of what viruses look like in comparison to other cells. So we have the coronavirus here. Generally, viruses are around 20 to 250 nanometers. Coronaviruses tend to be around 100 nanometers. If we look at bacteria, they're a bit different. So you have a lipid bilayer, and you have your DNA, but the DNA is not collected into a nucleus. So prokaryotes or bacteria don't have a nucleus. They're larger than viruses. So typically bacteria would be around 500 to 5,000 nanometers. And a typical E. coli would be 2000 nanometers long. So approximately 10 times larger than the coronavirus. But if you look at an animal cell, you see a lot more of complexity. You have a nucleus in the middle, which contains the genetic information, and you have a lot of different organelles within the cell, and it's surrounded by a lipid bilayer. Again, these are bigger. Typical eukaryotic cells are around 10 to 100 micrometers in diameter. And note that we changed the unit, so we're up in micrometers instead of nanometers. And a typical epithelial cell from your airways would be around 10 micrometers wide. So another step upwards in size. So what happens when a virus enters your body? Well, this is an example. This actual illustration is based on the Zika virus, so it looks a bit different than the coronaviruses. But what's common for all viruses is that they have some sort of receptor, some mechanism with which they can identify and bind to eukaryotic cells. And they can then enter the cell, and the DNA or RNA in coronaviruses, the RNA is released into the cell. And then the RNA can be replicated. So they make multiple copies of the RNA. And they also produce the proteins that are coded for in the genetic material. So essentially, viruses hijack the cellular machinery and start producing the building blocks of new viruses. And as these building blocks are being manufactured increasingly, they self-assemble typically. They would do that spontaneously, where they collect all the genetic material and the proteins that they need into new viruses, which are then either budded off from a live cell, or it will just burst open the cell, and that way it would kill the cell. So it multiplies several times during in its life cycle. Now the response from our bodies contains essentially of three different things. We have cytotoxic T cells, so our white blood cells, or a group of our white blood cells that are able to recognize infected cells. And they launch an attack against our own cells and kill them. The other part is that we can release interferons, which inhibit the replication of viral genetic material, but also the neighboring cells of the infected cell express some substances that increase the T cell, the potential of T cells to recognize that there's an infection going on, which will then launch a cytotoxic reaction. And we have the specific immunity in terms of antibodies. And these antibodies are generally specific to a certain substance. And due to that, it takes a few days perhaps to create new antibodies if the infection is not known previously by the body. But the antibodies are able to identify the virus. They bind to the virus and induce what's called phagocytosis. So another group of our white blood cells can then recognize the antibodies and essentially eat up the virus. So viruses can be transmitted just like any other infectious agent. So I'll be focusing on coronaviruses now, and especially the new COVID-19 virus. So it enters our bodies through our eyes, our nose, and our mouth. And it's transmitted mainly by droplets that come when we cough or when we sneeze. In some special circumstances, there may be aerosols that carry these viral particles. That's more when we're talking about hospital care. But they can also be transmitted through some surfaces, because the virus can survive for a number of hours on contaminated surfaces, which means that if person A sneezes on a restaurant table and person B comes in 1 hour later, sits at the table which has not been properly cleaned, he can get the virus on his hands and then through the food get it into his mouth, and that way become infected. So is there any way to prevent getting infected? Well, vaccines are generally a very good prevention measure, but we don't have any vaccines against coronaviruses. So it remains to be determined if we can get a vaccine. There are some trials going on and a lot of research going on, but we don't know so much about the immunogenicity. So how strong an immune response can you get from a vaccine, or how long it will be efficient. So in the meanwhile, we'll focus on the simple things of life. The same methods that were used globally to stop, for instance, the Spanish flu during 1918. Hand hygiene, washing hands with soap and water for 20 to 30 seconds, and making sure to actually get the soap all over the hands and a bit on the underarms. Soap is very efficient in clearing coronavirus particles. So it kills the virus and it removes loose virus particles from your hands. If you don't have access to soap and water, hand rubs, alcohol-based hand disinfectants are also effective. Can also prevent spread by covering our sneezes and coughs. So generally you would say that if you need to cough or sneeze, do that in your on the inside of your elbow, so to speak. And keep an appropriate distance. Recommendations are at least 1 meter apart from other people who could be carriers of the virus. And then we have the question of protective equipment. Facial masks, gloves, aprons, and so on. My personal opinion, and which is also shared by many other professionals in the field, is that personal protective equipment is to be used by healthcare staff, but not so much for the general public, with the exception that if you do have some sort of respiratory tract infection, you can use a simple surgical mask to prevent any droplets being transmitted from you to your environment. But if you choose to use one of these masks, you need to dispose of the mask in a safe way, because whenever you're breathing or coughing inside the mask, it'll build up with virus particles, and then that mask itself will become a potential contaminant. So, treatment when you do get the new COVID-19 disease, how do you treat it? Well, this will be an exhaustive list of the available medicines that we have, which are tested and found to be working. Yeah, that's it. We do have some clinical trials ongoing. These are some examples. Remdesivir, which is an Ebola drug, which can inhibit RNA polymerase. And we have chloroquine, an antimalarial drug, which may reduce virus attachment. We have a combination of two antiretroviral drugs, which are believed to be able to inhibit the replication. And we have a combination of these two antiretroviral drugs combined with also interferon beta. And also there's one combination being tested with chloroquine and azithromycin, I think it was. But then in hospitals, what you have access to is essentially supportive therapy. So support the vital functions of the patient. And it may be oxygen supplement, so breathing in oxygen through a general mask. Or in really severe cases, you may have to put the person in a ventilator, so an invasive ventilation. And of course, strong inflammation reactions can be countered with steroids as well. Well, antibiotics then, can't they be used? Well, by definition, antibiotics are not effective against viruses. So basically, no, antibiotics won't help. However, in one of the studies that came out from Wuhan, they showed that in severely ill patients, almost 50% had a secondary bacterial infection. And in that study, all of the patients except one got antibiotics, but still died. So it's not 100% clear if it really is the secondary bacterial infection that actually, or how much the secondary bacterial infection contributes to the death of the patient. And this is a figure from that paper that I mentioned. We have two graphs where the top one is people who survived the disease. They had fever for almost 2 weeks. They had cough over the almost whole period. But after a week, they started getting dyspnea, so difficulties breathing, and they would probably have gotten oxygen supplementation. But during day 9, you see that they develop a sepsis, which is essentially your immune system running amok while trying to contain the infection. And on day 10, they would develop an acute respiratory distress. They would end up in an ICU and get systematic steroids to reduce the sepsis reaction. And during all of this time, from day 1 up to day 2 or 21, they were positive for the virus RNA. So viral RNA was found in these patients for almost 3 weeks, which means that there are actual virus particles in the body. Now, looking at the non-survivors, so those who died, again, fever, they had cough, just like anyone else. They started developing dyspnea. They were admitted to an ICU, and 3 days after admission, this would be a typical patient. They would require invasive ventilation, so they would be intubated. They would also get systematic corticosteroids because they developed sepsis around day 10. And these patients would have died during day 19. And here's the interesting thing about secondary infections. So you see that we have a sepsis, again, day 10. These had around day 9. So noteworthy is that this is a viral sepsis, not a bacterial sepsis. And then they start developing acute respiratory distress. The people who died eventually started getting cardiac injuries, kidney injuries, and then on day 17 they got a secondary infection, and they died within 2 or 3 days after that secondary infection. So it seems, at least to me, that the secondary infection is sort of the last straw that breaks the donkey's back, or however you want to express it. So yeah, maybe the antibiotic, well, obviously all of these patients at the ICU would get antibiotics, and I don't in any way criticize the decisions of the ICU staff to give antibiotics, but probably the secondary infection didn't have a huge impact on the outcome for the patients.